Hello, everyone. Thank you for joining us in this webinar presentation called Addressing Unique Challenges and Treatment Approaches for Young Adult Chronic Pain Patients, hosted by the Society for Health Psychology's Adolescent Young Adult Interest Group and the Pain Psychology Interest Group. This event is provided as a free benefit of membership in the Society for Health Psychology, and we really appreciate you joining us today. I am Lila Pereira, chair of the AYA interest group. Before we begin, just a few items to share. As you saw a moment ago, this event will be recorded. Anyone who speaks during it, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted to our website. Please keep yourself muted until later on at the end of the presentation, and then you can ask any questions then. You can either submit them through the chat feature throughout if you'd like, or raise your hand at the end, and then we will call on you to ask your question directly. Now I'm going to turn it over to our first presenter, Dr. Donald Marks, to begin the presentation.
All right, great. Well, good to see everybody here, and nice to be here. My name is Don Marks, and I am associate professor in the Department of Advanced Studies in Psychology at Kean University. And I have with me today Dr. Amanda Rhodes, who is a research psychologist at the National Institutes of Health. And I just will give her an opportunity to introduce herself.
Hi, everyone. I'm Amanda Rhodes. Like Don said, my primary faculty appointment is at the National Institutes of Health as a research psychologist. I'm housed within the pediatric oncology branch in the health psych lab, and we basically do a characterization of disease and treatment in our young cancer patients. We do also do some adult populations, cancer predisposition syndromes and other chronic illnesses that experience a lot of pain, like sickle cell disease. I also have a secondary appointment as a clinical assistant professor at the George Washington University in DC. And I also own and operate a small private practice in the Bethesda area, really specializing in patients that have chronic illness and pain. So I'll pass it over to Maureen.
Right, and then we also have Maureen Sessa with us today. I'll allow Maureen to introduce herself.
Sure thing. Hi, everyone. I'm Maureen Sessa. I'm a third-year doctoral student at Kean University. I work pretty directly with Dr. Marks. I have had the privilege to work with chronic pain patients throughout my young career, both at Kean and through a grant-based program through Independence Blue Cross, where we did a CBT-based initiative for individuals in the Philadelphia area experiencing chronic pain conditions and short-term therapy related to that. So I'm super excited to be here. If you all would just bear with me a moment as I pull up our slides for today.
Thank you. So while Maureen is doing that, I'll just give you a little overview of what it is that we're going to do for the next hour. So we have a relatively broad program for you here today. So we're going to talk specifically about the issues concerning chronic pain in adolescents and young adults. We're going to look at chronic pain treatment in the context of healthcare, and then specifically at psychological treatments, some of the evidence-based psychological treatments for pain. It's going to, given the time that we have, it's going to be pretty broad brush with that. I'm also going to talk a little bit in that segment about some important treatment considerations, particularly having to do with relationships and family. That's a significant consideration when working with younger people, obviously. Then we'll have a brief segment on assessment of pain, and then hopefully enough time once we get through that to have some discussion. If you have questions along the way, I think you could feel free to interrupt us. That would be fine. If you want to put questions in the chat, we might miss them until we get to the end. But if you do put something in the chat, we'll definitely try to get to it at the end. Okay, well, that's the game plan, and I'm going to turn it over to Maureen to get started.
All right, fantastic. Okay, so we are all here really to talk about the specific considerations in relation to young adults and chronic pain experiences. I know Dr. Marks mentioned it briefly at a point in time, saying that a lot of the experiences we may have in this field is working with chronic pain patients that are a bit on the older side, middle-aged to older adults with chronic pain experiences. And from my personal work, that's predominantly what I have seen. But if we take a look at the literature and really what's going on here, chronic pain can start at a much younger age than we might normally think. If we're seeing that around 12% of young adults can experience a chronic pain, it's interesting to me that this is not as part of the larger conversation as it could be. So that's really why we're bringing it in here. We know that children can also experience a variety of different chronic pain experiences. We see around 11 to 30%. So this is continuing on into young adulthood. They might have varied experiences with their healthcare providers. They might have had no experience with chronic pain management at all. So we have a lot of different experiences coming into our office with these young folks. I would say that one theme you're going to notice as we go across our presentation is that a main component with an adolescent and young adult navigating their pain experience is going through the healthcare system and what that even looks like. Transitioning from a pediatric care system to adult-based work has a variety of different challenges. And we might find that an individual is in that 18 to 30 range cognitively, right? But with emotional aspects and with their chronic pain attached to that, we might be seeing a bit of a younger presentation, and we need to address it as such with our languaging and the interventions that we use. So we have to have a unique understanding of that before we even continue treatment with them. So we want to have that proper treatment, and we should start with proper conceptualization. So that's really where I wanted to open us up first. So let's talk about it. So in the research, there's a variety of different factors related to how we should go about conceptualizing adolescent and young adult pain. And you'll notice that not all of these factors are inherently different from what you would see with an older population. We're just kind of tweaking it a little bit to fit the group that we're working with. So some of these might relate to someone in an older life state. But what I saw for the most part in the literature are these very big constructs related to identity: school, work, social factors. So if we start at the top here with school performance, we never know. Anybody could be in school at any time, but we usually associate this with a time period of young adulthood. This could be leaving high school, entering college or an associate college, a trade school, what have you. But along with that, when an individual has a chronic pain experience, comes all the stress of what it's like to be in school and being a student. So we may see some factors related to being able to attend school. What's that like when this person is in the classroom? Are they able to focus, or is the pain a little bit too much? Does it lead to a sense of absenteeism? Are they able to focus and concentrate on their assignments and turn their assignments in on time, or is the pain getting in the way? If there's a flare-up of the chronic pain experience, do they feel comfortable talking to their professors about the fact that this is going on and they might need additional time or a bit more flexibility? Regardless of what the answer is, we would need to understand that to see where our intervention points could be. On the bottom left, we have work-related factors. So again, just like adults in really any walk of life, young adults are getting into the workforce, starting a job maybe for the first time, a career transition, figuring out what they want to do. But we also need to consider how that workspace is playing into their pain experience. So similarly to school, are they able to get to work on time? Is it a comfortable space for them to be in? Are they able to speak to a higher up if there is a health-related concern? Can they get proper time off to go to their doctor's visits and have it be counted appropriately? Is there any sort of stigma related to that? And now we can really consider this last point of the option for virtual work and what the benefits and consequences of that might be. This might be something that initially may seem really attractive to a young adult with chronic pain, but is it actually going to be helpful for them for understanding their pain experience, getting back out into the world, navigating other relationships? And that should be part of the conversation as well. Finally, we have social identity, so peer groups, different relationships, intimacy in relation to chronic pain. With the college age population, I mean, there's so much social transition that occurs with those individuals. And that could be the people you meet in your dorm. If you're on a sports team, what's it like being in athletics when you have a chronic pain issue? In your just in your different peer groups, are you able to actually discuss this with people that you feel close to? Is there that sense of trust? Is it a factor in your relationship? And if it is, what does that mean to you? So all just pieces to the puzzle here. Continuing on just a little bit broader or two, we have different aspects of life, right? We have family life, social life, and internal life. Now, of course, social life and social dynamics can be similar, but we want to pull it out a little bit to see a broad scope of what an individual's experience is like. Because in all three of these, we can see similar themes. We can see role changes, we can see strain in relationships, and we can see identity development. So what I mean by that is, let's take family life for an example. Let's say before someone's chronic pain experience, they were really the go-getter of the family, really taking care of all the needs for their siblings. They were driving their siblings everywhere, were able to help their parents out with chores. Nothing was ever a bother. Then we have a chronic pain experience and things have to change in order to account for what's going on for that person in their body and their mind. That can cause a lot of strain within the family and changes within who you are in relation to those around you. So there's a lot of confusion that can come with that. Who am I if I am not this role that I've known for so long, or I assumed I was going to take on in my later years? So it's always important to take that into consideration. Beyond confusion, though, we might see some common emotions come up with young adults. There's this sense of anger that this is happening to someone so young. There's a feeling of grief and loss in relation to having a condition that maybe was not expected, or taking a look at their lives and thinking, wow, I am probably going to have this for the next 50 years. What does that mean for me? This is not who I expected myself to be. And we can see what we can make of that. And there may even be some embarrassment or shame in relation to it too, if there are role changes or feeling as though you can't be the person that you thought you could be going forward. Now, of course, that would be something we work on in treatment, but these are things that you might hear in the room with a young adult. So speaking of which, I wanted to bring in a case that I worked on pretty recently. Very grateful that I had this experience. So I worked with an individual in her mid-20s who was dealing with chronic pain as a result of non-alcoholic fatty liver disease. She developed her chronic pain condition probably about 6 months or so before I saw her. So this is a fairly new experience, but this was a really go-getter of a person. You know, she was pursuing a graduate degree, working multiple jobs at the same time, very family oriented. But she was finding that over time that this pain could no longer be ignored. That was her typical coping strategy of, if I just push this down as far as I can continue with all of my roles exactly as they are. And I'm sure all of us who work with chronic pain patients know that's not necessarily the case. We anchor and we adjust, right? So some themes that came on in treatment were talking about what it means to be in her family now that this chronic pain experience exists, as well as dating life. Is this something that you disclose? Is it something that you'd like to keep to yourself? How does this impact your ability to go on dates or go to family functions, especially with her particular condition in that she was immunocompromised, and in the culture that we're in now, in the context, everything had to be a bit more secure. So we would often have discussions about that and what made her feel comfortable. She would often struggle with figuring out how to attend class and meet deadlines without it leading to a major flare-up. She was very good at scheduling her time and making sure that things were done, but it was at the consequence of her body. So we had to talk about what is a way that we can maybe shave off some of these responsibilities that still get you to where you want to go, but it's taking care of yourself and being compassionate to yourself in the process. And definitely loss was a part of the conversation too. It was typically focused around the emotion of frustration And so we would peel back those layers and show that this was not the identity that she wanted going forward, but it's the identity that she had, or a part of her identity, right? A part of it. And how can we incorporate that into the rest of who she was, since she was an amazing person. So I just wanted to show that these little themes can come up throughout our work. So I think, yep, Amanda, you're on.
Yeah, so I'm going to take it for a little bit. First, I just want to pause. That was a really wonderful job explaining a specific case. And then what I'm going to talk about in the next few minutes is expanding our perspective and understanding really where this person is once they've come to your office seeking some sort of help or treatment. How did they get there, right? So we can't do this work unless we really understand the context in which they're living. And in our AYA population, our adolescents and young adults population, it's already a very vulnerable population because there's so many changes, developmental changes and social changes that are happening. And, a lot of times it's graduating high school or things like that. And so with our pain patients, we're actually adding this like healthcare context into it. And unfortunately, we don't do a really good job catering to our AYA population. I just saw somebody the other day that she was on a study of mine as a pediatric patient, young adult or young kid patient. In the time between her follow-up visits turned 18, she comes to me and then I have to reconsent her as an adult, right? And she hardly has an understanding. So I'm sitting there with her trying to figure out if that's developmentally appropriate. And all of a sudden at 18, at birth, because of her birth year at 18, they're like left up to their own devices. They had to switch hospitals. Their pediatric hospital no longer took them. They're going into an adult hospital now seeing them. Their whole context has changed. Okay, so in that healthcare system, the medical system that we have, especially in the United States, most chronic pain research, as you guys all know, has been conducted with this either average pediatric patient, which is like an older child or adolescent, or an adult, right? And that middle-aged adult, 40, 45, big standard deviation there. But that really leaves a gap for our young adult population, And so little research has had attention on understanding, first of all, clinically meaningful outcomes, and then strategies, of course, in pain treatments, and how to reduce these disparities. And so this is definitely a topic that is near and dear to my heart, and where we don't do that good of a job of it. So I'm really happy that we're doing this webinar. So in terms of AYA pain specifically, it does look a little bit like what we might see traditionally with older adult pain, meaning that females in AYA, that range, do report higher levels of pain than males. The AYA specifically report higher levels of pain interference than adults over 35, which I find really interesting, probably because there's an expectation for young adults and kids to be in social activities. And so when they get missed, there's a discrepancy and a distress that comes with it. And then also AYAs have more healthcare needs than adults over 35. And it's probably due to the fact that when there's chronic pain happening with AYA, there's also likely comorbid underlying physiological things happening. So therefore, there's vulnerabilities that kind of emerge for this young adult and adolescent population. And those vulnerabilities, which I'll talk in the next slide, relate to kind of some health risk behaviors for our young adults, and also this poor access of healthcare has significant implications of chronic pain management. And what we're going to do today is we're going to take our chronic pain treatments and we're going to tailor them to an AYA population, because that really doesn't get done. So most of our research gets done with the average adult patient. And so we're going to take that research and see how can we implement it with our younger folks. So if you want to go on to the next slide. So AYA, adolescents and young adults, is a very important developmental level. It's typically defined as 16 to 29. And I say typically because we don't define it well. You might define it one way, I might define it another way. I work in pediatric oncology. I've told Dawn this before, I sometimes will allow up to 35 in our peds unit. It's really astounding that there's no marker. And that's because developmentally, it's not just you turn 18 and you have an adult brain. We all know that, right? What's interesting specifically about this population, like Maureen said, is our chronic illness, which is very much comorbid a lot of times with chronic pain in our young adult population, our chronic illness population tends to developmentally appear a little bit younger. It's probably because they've missed some school, they've missed some social interactions, they've missed learning opportunities. It could be they're actually disease and treatment, depending on what it is, central nervous system, brain tumors, things like that. But generally, AYA is marked by this occurrence of neurobiological, psychological, and behavioral changes, right? So that the young adult teenage brain goes through changes, white matter, gray matter, that kind of all inverts at the same time, a perfect context for vulnerability. And so also this attainment of societal milestones is really important during our young adult population. And then these contextual life changes. And what I mean by that is there are some health risk behaviors that start to get, they start to play around with, like smoking or substance use. That kind of occurs for the first time in the teenage young adult populations. There are some difficulties with our AYA with medical regimens. I do a lot of adherence-based research, and what we found that children, because their parents, like the young peds, because their parents are very much involved, they do a little bit better with adherence. Then they get to teenage years, there's less parental oversight, and our teenagers and young adults really are not great with adherence. So that is contributing a little bit. We also see in that young adult population some decline in physical activity, increased obesity. So it's really important to understand that AYA specifically after they turn 18, often have experience difficulty accessing their own healthcare. All of a sudden they are having to make their appointments or not making their own appointments. Whereas before there was a lot of hand-holding under 18 as a traditional pediatric patient. All of a sudden they turn 18, no more hand-holding, we don't do a good job transitioning them, and so then they have a lot of difficulty accessing healthcare. And that could be because of loss of insurance coverage, right? They could have been under their parents, now they're not under their parents. It could be the transition from pediatric care to adult care, that gets really murky. And there could be also just organizational and provider and patient barriers that result in these older adolescents and young adults kind of being less likely to seek care. So if you want to go on to the next slide, it's also important to understand that when an AYA or anyone really comes into our office, they are very likely being referred by someone that's very heavily embedded in the medical model in the United States, right? So that's likely how they got to us. They've tried all the other treatments that their physicians or nurse or whoever they came from and said, I just cannot do something about your pain. Let's try this. So it's very likely that they've been in some sort of hospital medical context. And that's really important for us to understand because they're coming in with a perspective that is philosophically mechanistic. And what I mean by that, just bear with me, what I mean by that is that pain is either real or kind of not real, psychosomatic. And that the body, right, from their referrals, where they come from, the context, depending on if they have a medical illness that they've been treated for, their body is often conceptualized as like kind of a collection of parts and relations and forces, like this biomachine, we kind of call it. And in that, right, there are defective parts, relations, forces that cause particular signs and symptoms to occur. Now, some of that might be true, like if they have a comorbid chronic illness or a physical illness or acute illness that's causing pain. But the medical model, what it does there and what they're coming from is that they work backwards. It's like we look at the signs and symptoms and we work backwards to identifying this underlying pathology. And then if we cure that, we ameliorate the impact. And that works really well when it works. However, if you remember, it's chronic pain, right? So it's not acute pain. It's a little bit different. In those words, we can tell that it's happening. It's happening for a long period of time. The challenges with pain specifically are there's multiple forms of physical pathology that produce common signs and symptoms. There are behavioral histories and contexts that interact with physical pathology that produce signs and symptoms. And then there are also common sources that produce lots of different signs and symptoms. Chronic pain has challenges with all three of these, right? So the medical model of pain really creates a context that kind of sets us up for failure and how we view and conceptualize pain. If you want to move to the next slide. So that in the medical model of pain, there are 3 types of pain. I'm not going to spend a lot of time here, but there's nociceptive pain, which is caused by damage to tissue. So you can think like your sharp, achy feelings, like external injuries, sports injuries Dawn was talking about earlier. There's your neuropathic pain, which is kind of related to dysfunction of the peripheral central nervous system. And then there's the psychogenic or psychosomatic pain, and which is caused by, psychological factors. Traditionally, beliefs is what they say, or fears or strong emotions. And what's important about this slide is that the distinctions may seem intellectually clear, and sometimes they certainly are, but they also imply that most pain syndromes can be traced back to either 1 or 2 of the pathological aspects of pain. And that's just not how it happens. Like if you ever have worked with anyone with pain, especially young adults, it's like a combination of all 3, right? And so it's just not that intellectually distinct. And that's where it gets murky. If you want to move on to the next one. So in terms of our traditional approaches to pain, once our kids or young adults have come to us, it's very likely they've tried all of these, right? Or they've tried at least some of them, because they've been embedded already likely in the medical context. So these are some traditional approaches to pain. Likely they've tried a lot of them. They're coming to you because it didn't work in the traditional sense of it didn't decrease their pain. If you want to move on to this next slide. I want to highlight here that human beings are very complex, right? So they are biological, yes, we are biological. And we're also developmental, which means we learn, right? We experience growth. We are historical, meaning we have stories, and we language, and we're going to talk a little bit more about languaging later, but the way in which we describe our experience cognitively impacts and is related to how we develop and how we feel throughout the world. So if you want to move on to the next slide, this is the alternative to the medical model of pain. And this is the biopsychosocial model of pain. I'm not going to spend too much time here because I know you all know what the biopsychosocial model is. This is it just related to pain. So some of the things that we look at in terms of biological factors are, is there disease nociception? Is there inflammation happening? Is there brain functioning depending on the type of pain? We looked at genetics, physiology, neurochemistry. And then also the psychological factors, which I think particularly, and the social factors, which I think particularly we're interested in, right? So mood, affect, stress, how does stress relate to pain, coping, self-efficacy, anger, hypervigilance. So all of these kind of areas of the biopsychosocial model produce our experience of pain. And we are really interested in, as psychologists or psychology associates, whoever's in the crowd, we're really interested in the experience of having pain. Not necessarily the pain itself, but the experience that one has with the pain. So you want to go on to the next slide. So there are non-pharmacological approaches to pain. Oftentimes the number one is rest. The number one prescribed non-pharmacological approach to pain is rest. Physical therapy and OT are really great. Massage therapy might get introduced, neurostimulation like acupuncture, acupressure. And then of course there's the psychosocial therapy and counseling. That's what we're going to hone in on today. So we're going to briefly, in the next few slides, we're going to briefly go over some psychological evidence-based approaches to pain. It's really, we're not going to spend a lot of time on each. It's really out of the scope of this particular talk. But what we're trying to do here, because whatever context you're coming from or whatever theoretical model you're coming from, we're going to introduce it. And then we're going to really talk about the ways that we can tailor those disciplinary wise, tailor those to an AYA population. So I'm going to pass it off to Maureen, who really knows a lot about CBT for pain. She's going to start from there.
That's kind of you to say. Well, let's talk about it. Sure. So most of my experience working with individuals with chronic pain is from a second wave CBT lens, just the way that I was trained previously, and I happen to enjoy the model. We will be talking about other models that I happen to love as well, but I wanted to start with my roots, if you will. So I'm sure we all know the classic stance on the CBT model, right? We have thoughts, feelings, and behaviors, and all of these work together to create the perception of our internal and external experiences. But that's just the baseline. right? That's just the baseline of our human experience from this conceptualization. And now we're tacking in a very visceral piece that cannot be ignored of chronic pain. And the pain impacts all three facets of the model of cognitive behavioral therapy. Our thoughts are very much impacted by our pain experience. We can have strong emotional experiences in relation to our pain, regardless of what the emotion is. And that in turn affects what we do on the outside world. It could be how we conceptualize ourselves. It could be the way that we interact with other people, how we approach our job, school, intimacy, what have you. And it's really integral in this experience. So in CBT, we do talk about some factors that can bring on pain and some that can decrease pain. I'm sure some of you have heard of gate control theory. This is something that typically comes up in CBT work, but this is where we have points of contact, right? Talking about what can increase the experience and the severity of our perception of the pain, whereas something that can bring on a sense of understanding of our pain experience, the perception is a little bit less intense, even if the severity doesn't really change for this person. So we can see in this graphic here that there are factors related to all of human experience, what we think, what we feel, what we do, how we interact with others, and our physical sensations. And all of these, if we move towards the green side of this aspect, right, we're seeing that we can tone down our intensity in relation to how we relate to our pain. If we can pair it with a relaxation exercise, if there's another way that we can consider our pain catastrophizing thoughts, if there's a way that we can involve certain people that are important to us in our lives, or even sometimes tell them to take a step back, right? That can be a factor that can come up. But once we have that ownership of the pain experience with all these CBT dynamics, it might be a little bit easier to handle and move through the world. So to talk about that, again, these interventions are probably not going to be new to all of you. I'm sure you've seen them before, but it really takes a look at the physical and cognitive aspects and ultimately our behavioral, what we do. So in terms of that behavioral component, a huge aspect of it is activity pacing and activity scheduling, right? We want to make sure that what we engage in actually works with our pain experience. Does that mean we're going to have to cut something in half when we're engaging with it, when perhaps we could have done something for 2 hours in the past? Yeah, we can make space for that, and we can see how it can be helpful for us so that we don't bring ourselves into a flare-up. There's relaxation training. Again, I'm sure these terms are all familiar to you, but this is really about toning the experience down, getting in touch with really where the pain is coming from, getting a better sense and awareness of it, and knowing what to do if the pain rises and falls. So it doesn't feel like this experience that's going to lead into this catastrophic avalanche of a pain experience that's never going to get better. And then a huge part, at least in my experience of working with individuals with chronic pain from a CBT lens, to various ages, didn't really matter how old they were, was the aspect of catastrophizing. So of course that looks like the pain's never going to get better. I'm never going to get over this. This is the worst thing that's ever happened to me. No one's going to understand what I'm going through, right? And a core part of the work is saying, is there another way that we can think about this that is kinder, that is helpful, that is compassionate to ourselves, right? Because knowing that this pain experience may still exist for the majority of this person's life, right? If we're considering an AYA from 10 to 50 years, depending on when this person is diagnosed or experiences it for the first time, is there another way that we can take a look at this work and this thinking that is actually adaptive to living with chronic pain? If we're constantly fighting our minds and our bodies at the same time, that's a lot of suffering to go through. So having that little intervention piece with the thoughts will definitely be helpful, especially if this is going to be a condition that's going to be around for a long period of time for AYAs.
Okay, so the next model we're going to talk about, thank you, Maureen, is the ACT model, the acceptance and commitment therapy model. And this takes a little bit of a different approach. The message of often the pain therapies, like the ones that I talked about earlier, is that we should get rid of pain. We can do everything. It's kind of our culture. It teaches us at all costs, avoid pain. So try everything possible to just decrease the pain. So ACT suggests something radically different. And if you're not familiar with ACT, just bear with me for a few minutes. This is generally the model. Again, it's out of the scope of what we're going to be talking about today. But what ACT is trying to do is build up this construct called psychological flexibility. And what that means is kind of a perspective of being open and centered in your human experience, despite the inevitable presence of pain, and moving towards a values-based life. So even when pain shows up, could be psychological or physical, even when pain shows up, being able to move towards what you care about. Now, the difference is here we're really taking a perspective rather than trying to change. So if you want to move on to the next slide. ACT for chronic pain, it's newer than CBT, but it very much is an evidence-based approach. Lots of research recently has come out about effectiveness or efficacy of it, including the APA and the World Health Organization. And I want to specifically just mention here that especially if you can see in the UK National Institute of Health and Care Excellence, just recently ACT for people for pain, 16 and over, right? So some of it is also getting to, and the World Health Organization, children and adolescents with chronic pain, which is quite cool. If you want to move on to the next slide. Just a little bit about the research. Pain acceptance has been pain acceptance of the pain has been associated with lower pain intensity, less pain-related anxiety and avoidance. Avoidance piece is really key, less depression. Those are all great, but also really important, more daily uptime and better work status. So getting back out into your life. I want to move on to the next slide. So briefly from an ACT perspective, it's patients get stuck while spending more time trying to control and manage and alleviate their pain, and less time being spent in values-based activities. With our chronic pain patients, they are spending a lot of time trying to control and manage their pain. And that is really taking up a lot of really good resources, both physical, fatigue, cognitive resources that they could be spending elsewhere. It's also really interesting from this perspective is that when something gets avoided, right, the avoidance-based process, that kind of generalizes. So you can imagine when somebody wants to avoid their pain, anything related to that gets avoided. So you can imagine that doctor's office gets avoided, appointments starts to get avoided, school, maybe the area that pain started, like everything kind of starts getting, and our experience kind of constricts rather than expands. So if you see in the next slide, basically, and I'm not going to go into it totally here, but pain from this perspective is not the problem at all. It's actually the struggle with the pain that is the problem. And from an ACT perspective, with kids or young adults, some of the treatment approaches I might take rather than my older adults is I really tend to work from a more physical standpoint. Like mindfulness is a huge aspect of the ACT perspective. And I might work more with tangible objects in my mindfulness exercises rather than more existential, experiential, abstract exercises, only because developmentally, that's where they're at. So they really like that tactile exercises. Also, I tend to work with an identity piece more often with my kids or young adults because they get really stuck in who they are or who they want to be. And it's not a flexible sense of self. So if you want to go on to the next slide, Dawn's going to take it over to this rule-governed behavior part of our presentation.
Right. Yes. So these a couple of slides that I want to just cover here with you to talk a little bit about an aspect of behavior that is relevant to both the traditional CBT and the ACT approaches, and that is rule-governed behavior. Some of you may know, have had some exposure to acceptance commitment therapy, that it's predicated on a theory of language, which is known as relational frame theory. And a lot of at least a lot of the interesting work that's been done with relational frame theory from the standpoint of clinical application has focused on rule-governed behavior. So there are a couple of aspects of this behavior that I think we specifically want to identify when we're working with adolescents and young adults. And it's not to say that we don't also have to consider them when we're working with older adults, but they're going to have slightly different qualities associated with them. And so I'm going to share with you some thoughts about this, and then a couple of slides that I actually use with clients as a way of getting at the function of rules. So this is the first slide. So one thing that we've talked about already is that there are all these expectations around pain, and most of the expectations, particularly those coming from the medical model, highlight the elimination or reduction of pain. So I use these slides, which I honestly, I have to tell you, I don't know where I got them anymore. I found them at some point in the last decade on the Association for Contextual Behavioral Science website. And I've been modifying them and playing with them ever since, and I use these with clients regularly. So one of the things that I'll often do with a group of people is say, we say we're meeting in a room together as a group, and I'll say, imagine we're not here and there's a cat in here. What are all the kinds of things that the cat could do? And, you get a whole list of things. And then what are the various probabilities of the cat engaging in that behavior? And, from 0 to 100%, you get different probabilities for different behaviors: eating, hunting, sleeping, fear arousal, running away. Now, if you go to the next slide, imagine we bring a really big, mean dog into the room. Well, what happens to the cat's behavior at that point? Well, the repertoire of possible behavior shrinks, and the probability of fear arousal and running away goes way up. And this becomes a kind of useful metaphor for talking about the way that we've responded to pain, and about some of the more inflexible strategies that we employ around pain. And what's, I think, useful and kind of poignant about this is that it highlights the rule-governed aspects of relating to pain sensations. And at the same time, it acknowledges that pain is a very real threat. And so when we begin to sort of dialogue about what the possibilities for widening the cat's behavioral repertoire might be, we begin to think about ways that we can apply that in our own lives, and begin to take things that have been kind of automatically rule governed offline in that automated way, and actually explore them. So then I have a couple of other slides which I use similarly around pain. So imagine I'm in pain, what are all the kinds of things that I might do, and what are the possible probabilities of doing those things? Right. Well, here you see some possible suggestions of things I might do. I'm in pain, I have chronic pain, let's say, so I could do some of the things that Maureen was talking about in the CBT approach. I could pace myself, I could take a break, or, I could begin to engage in valued actions like calling a friend or talking to family, which would be consistent with the ACT approach that Amanda was describing. Or I could do things that I've been kind of trained to do from the medical model, see a doctor, use substances, medicate myself. There's a variety of different ways I could go. So we sort of see those probabilities, and we can have a discussion about that. Then let's move on to the next slide. Then what happens to my behaviors? How are they influenced? How does the repertoire change if we're operating under the control of the rule, I should be really successful right now. I should be engaged in the most important, earning period of my life and getting my foot on the corporate ladder right now. That's going to influence my behavior. And we could go on to the next one. Or what if I am operating under the control of the rule that anything is better than being in pain, that pain is absolutely dreadful? That's going to heighten certain kinds of behaviors probability and reduce the probability of other behaviors. So we want to look at our behavior under the control of these various rules. And then the other point that I wanted to address today, and I'll just talk about this very briefly, is that when we're working with any individual with chronic pain, we're working with the social support system and relational supports that this individual has. And so with adolescents in particular, we're working with family members, and it can be very useful to consider the relationships as you're addressing pain. My original training before I was a psychologist, I was a marriage and family therapist. And so I tend to think in family systems terms to some degree. All chronic pain occurs within the context of relationships, and our pain behaviors have relational consequences. So if I moan when I move, that's going to have a relational effect. If anybody remembers B.F. Skinner's theory of verbal behavior, the moan that I emit when I move and my back hurts can serve as a command for someone in my family to take action about my pain. And so these kinds of relationships and behavioral consequences emerge and are usefully looked at in the family. And then the other thing is that when we're working with patients, it's a really good idea to pay attention to this, because if we don't, we could be missing the function of the pain-related behavior. We could think that the way of sitting, the way of walking, the way of bending, stooping, moaning, whatever it might be, we could think that that is directly related only to the experience of physiological sensations. And that would be, I think, very unlikely to be the case. That whatever that behavior is happening in a relational context, and it's serving some kind of function in that context. One of my favorite marriage and family therapists, some folks may remember her, Virginia Satir, famously said, human beings cannot not communicate. So everything we do has this communicative function. And then we can actually involve family members in treatment. And I found this to be especially effective in working with individuals to involve couples, to involve partners, if possible. Certainly, if you're working with adolescents, you could involve other family members, but working with young adults, it can be really, really helpful to involve some of the people that they live with, including their partners, to examine how pain-focused attention is functioning in the relationship. Okay, and I am turning it back to Maureen here, I think.
Yes, I want to be cognizant of all of our time today. I'm recognizing it's about 10:02. So we don't have too much more to go over today, but this is kind of a summary of all that we've talked about so far. You know, we've brought aspects of conceptualization into the mix, the way that young adults may approach the system of healthcare or vice versa, you know, their own experiences in healthcare, as well as various different treatment regimens that an AYA could encounter when they're coming into one of our offices for behavioral management of pain. And so you might have noticed that across this, there's a theme of similar, but slightly tweaked when it comes to what we do with AYA, right? And a lot of that comes down to the language that we choose, having interventions that specifically fit the context of the individual who's coming into our door. And that's so similar to what we do with all of our patients, right? We'll treat an intervention as it is meant to be, you know, but if we need to make adjustments and make it more relevant to the person that's in front of us, we're going to do it to have comprehensive care. Same deal with chronic pain and young adults. You know, so our psychoeducation might be a little bit more focused on these social interrelational aspects of the human experience, because it's so prominent at this time of life, you know, and how pain can play a role in that, and how somebody wants to interact with their pain in relation to social dynamics. The language that we choose when we talk about certain interventions, or even being flexible of utilizing the language that a young adult brings to us. I can think of one patient in particular who was dealing with some physical concerns, and I brought in an analogy of taking your blinders off in relation to an experience, not only seeing it as the only experience in your life. And this client took it and said, you know, I really like this aspect of blinders, but what if it was a black cloud and I could just part the clouds and the clouds are near me, but they're not all that I can see? And I said, heck yeah, right? So we take this experience that they have, it tailors to their process, whether it's pain related or not. And it fits the context of how they'd like treatment to go, how we can make this relationship work so that there's better quality of life overall. So whether that's including more artistic expression, more tactile components like Dr. Rhodes was talking about, or even just the language that we choose, it's just anchoring and adjusting. It's just tweaking it a little bit to make sure that it fits who this person is and their age appropriate context.
Awesome. In the last two slides, I just want to address assessing pain from a developmental perspective here. The important thing to consider from us as a psychologist is, what is our function of the assessment? I don't know how many times at the NIH I might be in session, bedside inpatient with a patient, and probably 4 or 5 different people walk in and ask what their pain rating is. And so, what that's doing is that's taking a lot of concern at any given moment on when is this pain going to decrease. From a developmental perspective, it's really important to assess things that are really important for the AYA population, like education is really important, or vocational aspects of their life, independence from family. That's a period where they're really gaining or attempting to gain a lot of independence. Chronic pain can kind of get in the way there. And then also forming new romantic and social relationships is really important and really prevalent in this age group. So when we assess pain, it's important to remember that a lot of our standardized measures are for adults, or have been standardized for adults. So when you go to assess pain, on the next slide, if you want to go to the next slide, Maureen, here are some examples of assessments that we might use. Like I said, the numeric rating scale, there are some issues with that in the perspective we take on decreasing pain, which is a futile effort. I listed some process-based measures, which I really think are important here, like Maureen said, the pain catastrophizing scale. There's also the chronic pain acceptance scale, which is does a really, really good job taking perspective on never the severity of pain, but how much the pain is getting in the way of valued activities. So what is the control experience, and does that control experience decrease or increase? And then if you want to move one more slide, I just put it up here just so you can see some of the items. So number 1 item, I am getting in the way of business of living, no matter what my level, getting on in the way of business of living, and no matter what my pain is. So it's kind of more a process-based functionality perspective of pain. So now we have a few minutes left. If we want to open up, I didn't see any questions in the chat. If you do have any questions, you can go ahead and ask them in the chat or unmute yourself.
Yeah, definitely. Please feel free to unmute and ask a question. One thing, Amanda, I maybe would ask you, just as we're wrapping up, how do you, when working with a younger person, begin to address some of the problems around the quantification of pain and the monitoring of pain? My experience in working with athletes in particular on this score is that the constant assigning of numeric values to pain in a way reifies the pain and instantiates it in their lives problematically.
Yeah, it's a great question. Clinically and therapeutically, hopefully there's been some values-based work done and some awareness on how you want to spend your time. So if I had a magic wand, despite pain, how would I want to show up for my life? How would I want to be as a human, right? And so an assessment-based question that I use all the time, whether it's a validated clinical outcome or just in my therapeutic work, is in any given moment, how much control does the pain have in getting in the way of values-based behavior? Or another way of putting that is, in any given moment, how are you participating or showing up for values-based behavior, right? So often that's not even asking about pains, right? So even when the pain experience is really showing up, I really want to know assessment wise, are you in your life?
What are you doing?
Something that you is intrinsically meaningful for you? That's really, really important, right?
Yeah.
Because a lot of times with these patients, it's a 10 out of 10 all the time, right? They have chronic pain. And so despite that, can their experience be one that's additive of values-based and meaningful activity? And that's the assessment. That's really what I'm assessing.
Yeah, very good. Thank you. Yeah.
I actually have a question that I think is a little bit more specific and applied, but I was wondering about what your thoughts were, especially, I think that during this time where we're transitioning, right, different people's roles in the patient's lives, are there any struggles that you guys face in terms of how to involve like a caregiver, whether they're a parent, whether they're a spouse, or some other close person in the patient's life? How does that inform your work?
Yeah, that's a great question. I think it's a delicate balance. And one of the things that you've got to consider from a family point of view is that the pain and the pain behaviors are going to have a functional dimension within the family. And at the same time, there's a move toward greater autonomy that's happening developmentally, as both Amanda and Maureen described, for individuals in this age group. And you don't necessarily want to undermine that. And at the same time that's happening, most of us, having grown up in families, are familiar with this. It's not always easy for parents to let that happen. And so especially if we're working with an adolescent or a young adult who's been ill for some time, they've done some of their growing up inside the medical context, it's really hard often for parents to feel like it's okay, like somehow they would be abandoning this child if they let them get on with their own life, and the individual's feeling kind of smothered by it. And even with that in mind, which I do think you want to have a clear focus on, there's going to be opportunities where avoidance is made possible by taking the path of going home, going to mom or dad, going to the safe haven of the family, and seeking some kind of support, using pain as the rationale for that. So sometimes one of the things that I'll work on is differentiating between an adult request for support, relational support, and relying on pain as the means of communicating a request for support. So there's a lot of subtle and nuanced aspects to the family work here.
I think I just received, I'm sorry to whoever sent this. I think you sent it in a direct message to me, but it looks like it's a question about CBT approaches. So I can just read this for everyone. So this individual is curious about approaching activity pacing and scheduling from a CBT perspective for AYAs. That's an interesting question, right? Because if we're considering this particular age group, more often than not, they're pretty active. We consider young adults to be at the beginning of so many different aspects of life, socially, work-related, school-wise. Depending on the age, it could be buying a home, starting a family. There's so much that is happening. And because there's so much activity, if there's chronic pain in the mix, there needs to be a process of making sure that all of these needs can be met to a certain extent, but in a way that doesn't bring on a flare-up or interrupt the pain experience to the point of a higher severity level, right? So if we're working with somebody who, I'm thinking particularly of the client that I worked with recently, mid-20s, highly successful, very busy all the time. Even trying to find an hour for the two of us to meet for therapy was quite difficult because graduate students have a lot of work going on. I don't know what that's like at all, not me. But so we would talk about, what are the main activities in your life that bring you pleasure, a sense of mastery, a sense of identity? And are there ways that we can approach these activities that don't lead to a flare up? So sometimes that was breaking up the tasks into smaller chunks. Sometimes it was saving it for a day that you knew that there was going to be more periods for rest and relaxation afterwards, or meeting with a support person afterwards to talk about it, to have that verbal expression of what's going on for you. So it was breaking it up in pieces like that. And I think it can be successful to varying degrees depending on how busy your life is, but that would really be how I would approach this. How do we still have these things that are so meaningful and important to you and give you a sense of mastery? How can they still exist in the same realm as you having a pain experience? And they're still just as fulfilling. We're just kind of changing them a bit. So I hope that answered your question.
All right, we are a little bit over time, so I'm gonna suggest that we end here. Thank you again for attending the webinar. If you have any colleagues or students who would be interested in and benefit from a membership, either through the Society for Health Psychology, or if they're already a member to any of the interest groups, please invite them to join us. If you have any questions, feel free to email at apadiv38@verizon.net, or the presenters as well. Thank you again for joining us. And as Barbara mentioned, the slides, the recording will be posted to the website very soon.
Thank you, Lila. Thanks, everybody. Really good to spend the hour with you. And hopefully, if you have questions, you'll reach out and let us know in future. Certainly be happy to respond or dialogue by email. Put the email in the chat. Probably be a good idea. Yeah.